Yes, thank you very much, everybody, for your patience, just sorting out a few last-minute technical issues. But welcome to the next section of the webinar. My lovely colleague, Ram, is going to be covering DKA conundrums. So I will hand over to Ram to continue on with the session. Thanks.
Thanks, Linda. Two things to start with. One, I was quite happy if my video wasn't coming up, but now that my video has come up, you have to see my terrible hair. There's no hope until April for me, so you'll have to bear with it. And the second thing to say is that Maeve, one of my colleagues, was going to do this talk, unfortunately can't, so I've substituted on her behalf, but I've used liberally most of her slides. And thirdly, I've always had the ambition of asking for next slide, please, like Chris Whitty, and Linda's going to be my assistant today to do that. So bear with me as I keep saying next slide, please, every few minutes. So thank you, Linda. So we're going to talk about DKA and some of the aspects of DKA management in critically ill children. Now, we obviously have the BSPED guidance as our basis, but I've tried to focus on some of the aspects that are more relevant to critically ill patients rather than go into a lot of detail on the BSPED guideline. But that is really the basis, and the NICE guideline obviously are the basis where we would start discussions about DKA. Thanks, Linda. So next slide, please. So over the next sort of 45 minutes, we are hoping to cover what is DKA, but more importantly, what is not DKA. Trying to cover some of the aspects of the BSPED guidelines, but focusing particularly on some of these more contentious or more difficult topics regarding critically ill patients. So fluid bolus therapy and how much fluid and what fluid and when to give it. Persistent acidosis, which isn't really improving. What's the role of bicarbonate? What else can be done? Corrected sodium, how to use that, how to calculate it, what it means. Some notes about potassium therapy, which is clearly an area that comes up for discussion quite a lot on DKA patients. The value of a CT scan is obviously something that we can talk about. And then that old chestnut about the 16 to 18-year-old patient who doesn't neatly fit into our kind of standard referral pathways, but also can sometimes be on the obese side, and therefore the weight calculations can be difficult. So that's the sort of outline. There's a little bit at the end about COVID era and DKA, which, as you know, there's been lots of discussion about. So we'll cover some of those aspects as well. Thanks, Linda. So what is DKA? Well, this is the actual definition. Really, if you split it based on the D and the K and the A, it's very simple. So you need to have D, which is diabetes, defined by a blood sugar greater than 11 millimoles per liter. And that blood sugar may well be normal in a patient with DKA if they are a known diabetic already on insulin therapy. Whereas with a new patient diagnosis of a DKA, the blood sugar is invariably over 11 millimoles per liter. So that's the D part. The K part is the ketosis. The ketosis was usually detected when I was a registrar. We did ketone dipsticks, and if you had 2+ ketones in the urine, that was all you had. But over the last few years, we've got ketone measurement in blood, and the definition of ketosis in DKA is a ketone of level of more than 3 millimoles per liter. And then the A essentially reflects acidosis, and the definition in the NICE guidance is that the pH has to be under 7.3, or the bicarbonate has to be under 15 millimoles per liter. So those are the three sort of parts to the DKA diagnosis. Now, it's very easy to kind of split it like this and to describe it, but actually in reality, sometimes it can be quite confusing to make the diagnosis of DKA in some patients. So my next slide is a Slido question. And there you go. So you've got 5 choices of diagnoses that cannot be confused with DKA. So I suppose, just to make things simpler for you to understand, many of these can be confused with DKA, but which one can't be confused with DKA? So maybe if we have another 10 or 15 seconds and we'll stop. Okay, maybe if we pause there, and let's review what people think. So I think the key question was which of these diagnoses can be confused with DKA and which of these can't be. Now, just looking at the list as we go in order, acute liver failure at the top, I think that is the one that most people think cannot be confused with DKA, and which is absolutely right, because you would usually expect to see hypoglycemia rather than hyperglycemia. You would expect to see some acidosis, but it's unlikely that the acidosis is ketosis. So less likely or very less likely to be confused. Starvation ketosis. So you can get ketosis and acidosis with starvation ketosis. If you starve for a couple of days, then you can get mild to moderate ketosis and mild to moderate acidosis. Unlikely that you will get hyperglycemia. And some patients, obviously, if they don't have any glycogen reserves, will become hypoglycemic. But more often, because of glycogen storage, you potentially keep your blood sugar normal. Sepsis, again, acidosis is common in sepsis. Hyperglycemia can be common in sepsis. And we'll talk about the origin of the acidosis in a later slide, so we can sort of see what commonalities there are between DKA and sepsis. But essentially, patients with sepsis might have a stress response with cortisol, become hyperglycemic, become acidotic. Very less likely to be ketotic, but can be quite difficult to distinguish sometimes. Acute appendicitis and gastroenteritis, both abdominal problems, because DKA quite commonly, as you know, presents with abdominal pain, with vomiting, and features of an abdominal syndrome. So easily confused with acute appendicitis. Again, if you have a stress response, you get hyperglycemia from acute appendicitis, you get some acidosis, abdominal symptoms, and similarly with gastroenteritis. So many of these, so the bottom four have often been confused with DKA, but the top one, which is acute liver failure, is much less likely to be confused with DKA. So sorry for the confusing terminology of the question, but intentional. Thanks, Linda. So if you don't mind moving on to the next slide, please. Thank you. So BSPED Guidelines 2020 released in January, effectively used from April 2020. NICE guidance updated at the end of 2020 from the previous 2015 version. I'm sure you've all seen this, so I'm not going to go into too much detail, but essentially the bare bones of this is that there are certain clinical history features, some clinical signs, and some biochemical features that indicate the diagnosis of DKA, which we've just covered. And once you confirm the diagnosis of DKA, you then grade them into mild, moderate, and severe categories, which is based on the pH. And if the pH is less than 7.3, but over 7.2, that's mild. Under 7.2 and over 7.1, that's moderate. Under 7.1 is severe DKA. Now, one of the changes, as you are probably aware, of the BSPED guidelines and the NICE guidelines compared to previous versions, is the recognition at this stage of the diagnosis as to whether the patient is in shock, and then an action based on that recognition. So in this format, which is the BSPED guideline, shock is defined as reduced peripheral pulse volume, reduced conscious level, coma. And there can be obviously some discussion around this, and we'll do that as we go along. But this is a change, a conscious change from 2015 BSPED guidance. So what do we do differently in the 2020 guidance? Linda, if you don't mind moving to the next one, please. Recognition of shock on this basis leads to active resuscitation with fluid therapy. So obviously the airway and or an NG tube at the same time to be considered. And the reason an NG tube is advised is if the patient's airway is obtunded, if the patient is obtunded and the airway is compromised, then having an NG tube will prevent them from aspirating. And aspiration pneumonia is a complication of DKA, which can have significant side effects. Breathing, 100% oxygen, circulation, 20 mils per kilo of 0.9% sodium chloride. Now, the advice is to give 20 mils per kilo, repeat 10 per kilo until circulation is restored with up to a maximum of 40 mils per kilo before discussion with senior doctor. This is toned down slightly in the NICE guidance update from 2020 December, where the fluid therapy for shock is 20 mils per kilo and doesn't really re-emphasize or emphasize the need for more and more fluid up to 40 mils per kilo like BSPED have provided in their guidance. Similarly, grading the DKA into mild, moderate, and severe has been sort of de-emphasized into 3 grades by NICE just to have 5% or 10% dehydration correction rather than the 5, 7, and 10% dehydration estimation and correction advised by BSPED guidelines. So mild and moderate DKA in the NICE update are 5% rehydration and 10% for severe DKA. Now, in terms of intravenous therapy of non-shocked patients, the advice is quite similar between BSPED and NICE, so 10 per kilo fluid bolus over 60 minutes, unless they've already had a bolus for shock, and calculate the fluid requirements, correct the deficit evenly over 48 hours, and use 0.9% sodium chloride with 20 millimoles KCl in every 500 ml quantity. Before you do that, you check urine output and check potassium level. We'll come to that later. And start some insulin 1 to 2 hours after giving the fluid or starting the fluid therapy at a dose of 0.05, 0.1 units per kilo per hour. So that's the sort of overall outline of the new BSPED guidance. Do you mind moving to the next slide, please, Linda? So I think the first area to cover is the fluid bolus. I think there are a few points to highlight here, and I'm sure that we can have some discussion later. One is the definition of shock. Now, in this context, the definition of shock by BSPED mentions reduced pulse volume, decreased conscious level, coma. So not specifically in any order, nor does it say whether you need to have all 3 features or one of those features. Slightly less clear about the extent to which you need to have any of these. And I suppose one of the problems with this is that any patient with DKA is at risk of cerebral edema and decreased conscious level and coma, and therefore using that as the basis to treat shock or to diagnose shock and treat shock might become quite complicated because you are giving then more fluid therapy to patients who are already in cerebral edema. There is some interesting correspondence from the authors or the main authors of the BSPED guidance in the archives, which I'll come to later, which mentions that reduced conscious level and coma were never really intended to be primary determinants of shock in the BSPED guidelines. NICE guidance update in December 2020, thready weak pulses with poor pulse volume and hypotension. Again, not 100% clear whether you need both or whether you have just one and you're able to treat this patient as shock, but certainly slightly more specific than the reduced conscious level. Definitely one thing that is mentioned in both guidelines as not an indicator of shock is cool peripheries or poor capillary refill time, both of which will be affected by the hypocapnia that the patient usually has with DKA. So cool peripheries, poor capillary refill time are not signs of shock in this particular setting, and probably in many other settings, including sepsis. But particularly from a DKA perspective, cool peripheries and poor capillary refill time are not indicators of shock, and therefore not indicators of fluid bolus therapy in the way that the guideline specifies. Whatever fluid is given for shock is extra to the rehydration volume, so it's not included in the calculation for rehydration volume correction over the 48 hours. But having said all this, shock in this way, i.e. poor pulses and hypotension, is rare in DKA patients. And so therefore, the presence of shock in that way has to highlight other diagnoses such as septic shock or coincidental presence of septic shock in these patients. And the way to try and distinguish them might be to use lactate, because lactate will be high in septic shock, higher than in DKA. Fever, which clearly is an indicator of infection, may be present in DKA, but more likely to indicate septic shock if there's shock. And persistent shock that isn't reversing or correcting, so weak pulses, hypotension that is not correcting or reversing as you would treat DKA normally. So a few sort of tips to try and recognize septic shock. How common is that? I think the septic shock is reasonably common because we have seen few patients with pneumococcal sepsis, with streptococcal sepsis that have presented with DKA as their first trigger, first presentation, and have been quite difficult to recognize. So just remember, septic shock can be a complication and a confounder. Thanks, Linda. So why did the guideline change from 2015 to 2020 in both the BSPED and the NICE guidelines? And there is clearly a long set of documents that you can refer to on the NICE website about the reasons. But one of the reasons why more fluid has been advised is part of results that came from this trial. So this is a fluid trial, PCAN network fluid trial, which was conducted in the US in 13 emergency departments in the US. And this was published 3 years ago in the New England Journal. And this is obviously a big landmark trial for pediatric DKA, because if you look at previous papers, there's very little randomized controlled trial evidence of anything in DKA other than in small populations. So this is a big trial, and therefore clearly had a big impact on the guidelines. So what did they actually do? So they recruited patients with 0 to 18 years old with a DKA diagnosis, and the inclusion criteria was pH of 7.25 and below, or a bicarbonate of under 15. They excluded patients who had a GCS of 11 or under 11 from the second year of the RCT. And the reason for this is because their primary outcome, if you look at the primary outcome, which is this bit, is the deterioration in GCS under 14 in 2 consecutive readings in an hour in the first 24 hours of therapy. So patients who presented with severe coma, so i.e. GCS of 11 or under 11, were quite difficult to treat in the first year and randomize, because clinicians didn't have clear equipoise on how to treat them in this trial, and therefore they were excluded from the second year of the RCT. And I'll show you the impact that has had on the population in the next slide. But if you just take it from here, that the first year there were some patients with a GCS of less than 11, and for the second year there were no patients with a GCS of under 11 recruited to this trial. So already you recognize that what we normally deal with from a CATS perspective is a much sicker group of patients than this fluid trial. It's a 2x2 factorial design, and thanks, Linda. If you just move on to the next slide. What they did was have a fast and a slow group, and a 0.45 sodium chloride and a 0.9% sodium chloride group. So essentially, it's a 2x2 factorial trial exploring 2 concepts. One is fast rehydration versus slow rehydration, and one type of fluid versus the other type of fluid. So if you look at the 2 groups, or the 4 groups effectively, you can see the standard initial fluid bolus for all patients is 10 per kilo of 0.9% sodium chloride. That's the same for everybody. The next additional IV fluid bolus is 10 per kilo of sodium chloride, 0.9% in the fast group, but not the slow group. The slow group get no additional boluses. The assumed fluid deficit is 10% for the fast, 5% for the slow. And the process of replacing the deficit is different. So in the fast, you replace a lot of the fluid within the first 12 hours, whereas in the slow group, you replace the fluid deficit evenly over 48 hours, which is currently what the BSPED guidelines recommend, even replacement over 48 hours. Whereas in the fast group, the fluid was front-loaded effectively, so you got a lot more fluid in the first few hours. And you can see the fluid type was different because that was another concept was explored in the randomization, so 0.45 versus 0.9% saline. Next slide, please, Linda. So the characteristics of the trial population, this is obviously quite important and comes back to what we talked about earlier. So the patient age group was quite similar, as you can see, in all the groups. Under 6 years, which is obviously a high risk patient group, was not that different in all the sort of 4 groups. But at randomization, a GCS of under 14 was uncommon. Only 2% of the patients had a GCS of under 14 when they were randomized and entered into the trial. And that's for 2 reasons. One is, as I mentioned earlier, that clinicians had no equipoise for randomizing patients between these kind of groups. They had no equipoise, but also because one of the inclusion criteria for this trial was that they should be able to perform some neurological tests, clinical tests, to identify that they had mental competence. And obviously that means that anybody with a low GCS is going to get taken out of the randomization straight away. So 90% of the patients were a GCS 15 at randomization. Immediately, it's clear that this population is not the population that CATs are referred to from your side and the ones that you're asking for critical care support. Thanks, Linda. So the bottom line, just to cut to the chase here, is that their primary outcome was a deterioration in level of consciousness within the first 24 hours of treatment, and having 2 values of less than 14 GCS. And you can see that the confirmed decline in GCS to under 14 was 3% roughly, 3 to 4% in all groups, and therefore there was no statistically significant difference between a fast versus a slow, or a 0.45 versus 0.9% saline or sodium chloride. So effectively, a null result for both concepts, fast and slow, and 0.45 and 0.9. So I suppose that is one way to look at it. And the other way of looking at it is that, in fact, there is no reason to then recommend fast or slow administration of fluid in these patients. And so I suppose one of the reasons why things changed in the guidelines is to do with the fact that restricted replacement of fluid isn't really that much better or worse than the other. So moving on to the next slide. Thanks, Linda. This has clearly created and caused a lot of controversy. And as you can see here, fluid management has become now a sort of point of discussion. This is a letter that was sent into the archives a few weeks ago, in fact, from the South Thames Retrieval Service group from Evelina, who compared what the BSPED guideline would recommend, what the NICE guideline would recommend in terms of total fluid for different patient weights. So 0 to 80 kilo weights, total fluid given in the first 24 hours, based on each of these. And you can see that there's a lot of fluid being given according to BSPED guidance. Still a lot of fluid being given by the NICE guidance. But if you used a very restrictive regimen, as was previously recommended in 2015, then you would give much less fluid. So moving on to the next slide. So I'll kind of pause the discussion about whether fast and slow or a lot or less fluid is important. But I think the bottom line to say is that we can probably understand that the BSPED guidelines may apply to much less sick patients, but we don't really know what the impact of slightly more fluid in patients who are, who are critically ill is. We'll come back to to discuss this later on. So choice of fluid, there's obviously many different types of fluid that can be used: lactated ringers or ringers lactate, 0.9% saline, which is what is recommended by the guidance, and plasmolite A, which is, or plasmolite, which is a fluid that many of us are using more and more of. And the main advantage is that it has less chloride compared to the 0.9% saline. So moving on to the next slide, Linda. And the reason why that is now becoming more of a discussion point is because there is significant concern about hyperchloremic metabolic acidosis that chloride containing fluids or high chloride containing fluids result in. So just in 20 seconds explaining what this means, effectively, if you look at sodium as the positive ions here and the negative ions here in the extracellular fluid, positive ions are sodium, 140 millimoles per liter, and then a small amount of potassium, calcium, and magnesium. Negative ions are chloride, lactate, and there is a strong ion difference around 40 millimoles per liter when the chloride is normal, whereas when the chloride goes up, which often happens, as you know, with giving sodium chloride fluids, 0.9% sodium chloride, the chloride goes up and the strong ion difference becomes less, and therefore the patient becomes more acidotic. So they develop signs of metabolic acidosis, which is mostly related to the hyperchloremia. We don't really 100% know the impact of hyperchloremic metabolic acidosis, but in adults and in some pediatric papers, there's significant concern of hyperchloremic metabolic acidosis on renal tubular injury and acute kidney injury, so AKI. And therefore, there's been a concern about giving high chloride containing fluids, and plasmolite is obviously an alternative. If you move to the next slide, Linda, there's been 2 randomized trials. One very small trial here from 2017 comparing Hartmann's with normal saline for DKA patients. And then, sorry, if you move to the next one, the SPINK trial, which is recently published, which was a critically ill patient, well, pediatric emergency department critically ill patient study, where there was a double-blind randomized controlled trial of saline 0.9% versus plasmolite as the first fluid choice in DKA patients. So just if you just focus on this one quickly, any patient who was over 1 month under 12 years with DKA was recruited. If they were comatose, they were excluded. If they had known chronic kidney disease or chronic liver disease, they were excluded. Otherwise, they got randomized to having 0.9% saline or plasmolite as their first fluid choice. And the primary outcome was incidence of new or progressive acute kidney injury. And if you just move on, thank you. And their main outcome, as you know, was composite incidence of acute kidney injury, and there was really no difference. So I suppose, again, comparing 34 patients given plasmolite versus 32 patients given 0.9% saline, there was no difference in the primary outcomes of interest of acute kidney injury. So there is still lack of clarity on whether it is safe or not safe to use 0.9% saline versus plasmolite as a fluid choice for the first fluid boluses and subsequent fluid therapy in DKA. At the moment, the guidelines are still mentioning 0.9% saline, although the BSPED guideline does give you the option to give you some latitude to give some plasmolite. Okay, what's the next slide, please? Okay, so the next point we're going to talk about is persistent acidosis. And cats, we do get many calls about concern regarding persistent acidosis. So a classic example might be, so if we move to the next slide, please, that a patient is referred, a patient is admitted to the ED at around about 10 o'clock in the night. They have a pH of 7.047, a CO2 of 2.34, chloride, which is not available, a base deficit of -24, a lactate of 3.1, and a glucose of 51. their ketones are 4.3. A few hours after therapy, so that includes fluid therapy and insulin therapy, you can see that the pH has fallen to 6.91, the CO2 is 1.59, and the ketones have gone up to 5.1. So this might be sort of a classic example or case example of what might be referred through with sort of persistent stroke worsening acidosis over several hours. If you move to the next slide, please. Just very quickly then, thinking about why there is acidosis in DKA, and I won't go into too much detail, but essentially you produce ketones because of the effect of free fatty acids being converted into ketones in diabetes, in diabetic ketoacidosis, and you get two types of ketones, as you probably know, beta hydroxybutyrate, and these then cause hyperketonemia, which then leads to the acidosis. Clearly, hyperglycemia with osmotic diuresis resulting from that, and dehydration are the sort of other key components of why we see acidosis. So twofold: acidosis from ketosis and dehydration from losing fluid from hyperglycemia. Moving on to the next one. Thank you. It's a Slido question. So which of these is not a cause for persistent acidosis in a patient with DKA?
Can you not see it? Takes me a little while. Also, you usually don't get about that.
You may need to mute yourself, Linda. Sorry. There's a lot of chat in the chat window, which I'm going to try and ignore until the very end when we do questions. Okay, so maybe if we just kind of recap where we are with this, which of these is not a cause for persistent acidosis in DKA? I think the top contender here is too much insulin, and it's absolutely right. Too much insulin isn't really necessarily going to cause persistent acidosis. So thinking about the other ones, decreased GCS. So decreased GCS can lead to persistent acidosis if this affects the CO2. So for example, a hypoventilating patient from a decreased GCS, either because their airways become obtunded, airways become compromised from their obtundation, or they're hypoventilating, can lead to persistent acidosis because the CO2, which previous to the decompensation would have been in the 1s and 2s, has then started rising to the 3s and 4s because of the hypoventilation or the airway compromise. And so that could result in persistent or worsening acidosis. Too little insulin. So too little insulin causes the ketosis not to go away. So ketosis needs to stop in order to reduce the acidosis, and too little insulin clearly means the ketosis isn't going to stop. Too much, 0.9% saline, again, because of the hyperchloremic effect of 0.9% saline, you can get persistent acidosis from too much chloride, and that's another reason. Sepsis clearly can cause persistent acidosis and maybe one of the biggest confounding factors within DKA presentations. So just be aware, persistent acidosis may necessarily mean lactic acidosis from sepsis. So hopefully that was not that complicated as a question. So if we move on to the next one. So that's roughly the summary of it. So not enough insulin or no insulin, and ketones not coming down. So ketosis continues, acidosis gets worse. Hyperchloremia because of 0.9% saline, something else like lactate or toxins. It could be an overdose of a toxin. So just be aware that that's another little confounder there to think about, and obviously consider sepsis as one of the reasons why the acidosis may not be resolving. And as we spoke earlier, septic shock in the context of DKA may be a reason for the acidosis not improving and needs thinking about. Okay, if we move on to the next one, please. Simple things like, is the line actually working? Is there enough insulin going into the patient? Is the line leaking? And that is obviously something very simple, but isn't necessarily covered by some of these points. So just important to think about simple things like this. Next slide, sorry. Is there insulin in the syringe? Now, you may have put insulin in the syringe, but there are some confounders around when insulin might not actually work. So if you've left it out for a long time in the heat, insulin may not necessarily work and efficacy may not be guaranteed. So high temperatures, higher temperatures, probably the temperatures we might see 3 days in a year in August. But you do get, after a long time of being out, loss of potency of the insulin. So it's important to think about whether this is another reason why ketosis isn't settling down, whether the insulin isn't working. So if there is any doubt, remake up the insulin and put a new syringe through and see if that makes any difference. Bicarbonate. Is there any role for bicarbonate to decrease the acidosis in DKA? Well, the whole risk factor analysis of cerebral edema in children with DKA, and this is a very old paper from the New England Journal from Glazer and colleagues in the US, showed that treatment with bicarbonate in this case control study was a very high risk factor for cerebral edema, with a odds ratio of 4.2 and a significant p-value. So that was clearly a big risk factor for cerebral edema, and since then we are really reluctant to use bicarbonate in patients with DKA. Next slide, please. NICE guidance have nuanced this by specifying that if the patient has compromised cardiac contractility that's caused by life-threatening hyperkalemia or severe acidosis, and you have discussed with your friendly neighborhood intensivist, then you can give some bicarbonate. Now, in practice, I think we would very, very rarely or never recommend bicarbonate unless the patient was already intubated, ventilated on lots of inotropic support, which was not working because of a suspected acidosis impact on cardiac contractility. And that is very, very, very rare. And in fact, I've only seen it given once in the last 10 years on a patient who's already in multi-organ failure on the ICU. So not something that we would usually recommend because of the concerns about increasing the risk of cerebral edema. Next slide, please, Linda. Sodium. Now, one of the things that you realize when you ask for advice from CATS or when you look at the NICE guidelines or the BSPET guidelines is the concept of corrected sodium and calculating the corrected sodium and monitoring and tracking it. Next slide, please, Linda. So what happens with sodium? So, normally you would have a sodium in the blood of 140 millimoles per liter, glucose, say 4 to 5. DKA patients, there is osmotic diuresis, you lose salt in water, hyperglycemia is extracellular. And so there's osmotic shifts. And what you see as the glucose goes up, the sodium goes down, although that's not a true sodium. So that's why we do the corrected sodium calculation. So sorry, if you move on to the next slide. So for every extra 5.6 millimoles of glucose increase, sodium increases by 1.6. And so, for example, if the glucose is 45, then you can see the 45 divided by 5.6 is equals 8, and 8 times 1.6 is 12. So 128 plus 12.8 is 140. So your corrected sodium is 140, but your appearance of sodium is 128, and that's a compensation for the osmotic shift of the increased glucose. So the corrected sodium of 140.8 is what we track. The measured sodium, which is the 128, is really not that meaningful. And all you really want to track is the corrected sodium. The rate of change of the corrected sodium is most important in tracking the risk of plasma osmolality changes and risk of cerebral edema. So next slide, please. So the serum osmolality is calculated as twice the sodium plus glucose plus urea. And in this study from Desbone and colleagues in Toronto, you can see here that the plasma effective plasma osmolality comes down over time, starting with therapy. You can see here the plasma sodium and the plasma glucose. Obviously, plasma glucose comes down, but preventing a drop in effective plasma osmolality is considered to be one way of reducing the likelihood of cerebral edema. And so what that means in practice is, the next slide, please. A change in plasma osmolality, effective plasma osmolality, change in plasma sodium, plasma glucose. I'll skip to the next slide. It's probably more useful to look at from a corrected sodium perspective. Hyponatremia is probably protective, and a lack of rise or a fall in corrected sodium as you deliver therapy is a risk factor for cerebral edema. So what we would do is to measure the corrected sodium as the measured sodium plus the compensation for the glucose. And over a 4 to 8 hour window, if the corrected sodium is rising, but rising very high with sort of a measurement of more than 5 millimoles per liter over that 4 to 8 hour window, probably there is too little fluid being given. And if it's falling at a rate greater than 5, in that 4 to 8 hour window, there is probably too much fluid. So a lack of a rise or a fall in corrected sodium is a risk factor for cerebral edema. And that's why we calculate sodium, corrected sodium. So as you probably now guessed, the next Slido question is to get you to calculate the corrected sodium. Okay, so the admission sodium on this patient is 139. The blood glucose is 44. Now, 4 hours later, the sodium is 140, the measured sodium, and the blood glucose is 22. Would you increase the fluid that's being delivered to the patient, or increase or decrease the fluid volume delivered to the patient? Okay, I think everyone so far wants to decrease the fluid volume. Okay, maybe if we just pause there. I mean, I know many of you are calculating these numbers, but if we just go to the slides, we can have a quick look. So I suppose in a simplistic way, the blood sugar has fallen by 50% from 44 to 22, but the measured sodium has hardly changed from 139 to 140. So in a very simplistic way, since the blood sugar is halved, you would expect the corrected sodium to rise by a certain amount, whatever that amount might be, and you've really seen no rise in the measured sodium. It automatically implies that the patient has had either a lack of rise or a fall in the corrected sodium, and so that means that the fluid volume that you're administering is too high and therefore needs to be decreased. But if you do the actual calculations based on the formula, you'll find that the corrected sodium for the admission is 150, and the corrected sodium for the 4 hour sample is 144.6. So it's fallen by more than 5 in the 4 hours time period that you measured it. So it is quite complicated sometimes, but having a measure of and tracking the corrected sodium might be a good way to track the progress of the treatment and titrate the amount of fluid being delivered to the patient. Okay, next slide. We'll rattle through and maybe we can just skip through some of the other later slides, but essentially potassium. Profound hypokalemia is uncommon, but can be a significant complication of severe diabetic ketoacidosis. So for various reasons, and I don't want to go too much into detail. If you just go to the next slide, please, Linda. So the current guidance from NICE is to include 40 millimoles per liter of potassium chloride in all fluids, except the initial IV fluid boluses, unless they are anuric or the potassium is greater than 5.5. So if they're high potassium at presentation or anuric, you would not put additional potassium, but in all other patients, you would put up potassium into their replacement fluid, because hypokalemia will occur very quickly, even if the potassium level is normal when you start insulin treatment. So that's the current guidance. And clearly, the only exceptions are if the potassium is over 5.5 or they are anuric. So just move on to the next slide, please. And there have been case reports of patients arresting from severe hypokalemia, etc. And I know that sometimes correcting the potassium can be quite difficult. And despite giving 40 millimoles per liter replacement, they can have significant hypokalemia that needs further correction. And sometimes we do advise, if the GCS is not abnormal, enteral replacements to try and bring the potassium up for those patients. Just move on, please. Finally, and maybe we should stop here and take some questions, because there's so many interesting points to discuss. When would we do a CT scan in patients with DKA? We would do it when we are concerned about cerebral edema. And we would do it in patients with cerebral edema because we want to, A, confirm if they do have cerebral edema, but remembering that CT scan isn't a very sensitive or a specific marker for cerebral edema. The most sensitive and specific marker is clinical signs rather than cerebral edema. And so how useful is the scan is a question that you have to consider. And really, is it going to treat the patient, or is your treatment independent of the scan? What the scan might help you to do is to distinguish other factors in DKA that are causing the lack of decreased conscious levels. So for example, they may have a coincidental head injury or an infarction, or more commonly, dehydration resulting in cerebral sinus thrombosis, some kind of venous sinus thrombosis causing problems with their level of consciousness. So there may be other reasons other than cerebral edema that are reasons for doing the scan. In practice, the scan is, if the scan is negative but there are clinical signs, we would still treat. If the scan is positive and there are clinical signs, we would still treat. So therefore, I wouldn't really use the CT scan as an indicator of treatment, whether to treat or not. It may be useful to think about other pathologies that you might exclude from the scan. Just go to the next slide, Linda. Maybe just we'll stop with the obesity question. I think essentially the bottom line here is, and maybe just skip to the next point, next slide, Linda, is that there is now an upper limit recognizing overweight and obese children, that we treat a maximum weight of 80 kilos or a 98th centile weight for age, whichever is the lower weight when calculating deficit and maintenance requirements. And that is currently what the BSPED calculator allows you to do, which is that if you put in the weight of 110 kilos, for example, that you would be asked to limit it to 80 kilos. So that kind of gets around the problem sometimes that we have of very big patients, particularly aged 16 to 18, being given a lot of fluid and probably a lot of insulin if you calculate on the basis of their actual body weight. And a final point on 16 to 18-year-olds, the BSPED guidelines apply up to the age of 18, and so can be used up to the age of 18. And I think it may be worth just discussing how different people are using that in practice in terms of whether they are still looked after by peds teams or adult teams. And we certainly have had some referrals of adult teams starting treatment using the adult guidelines on 17-year-olds and 18-year-olds, where it's been then recognized that they should be treated differently, and a change in the treatment has been initiated, which then obviously makes things much more difficult in terms of calculating how much fluid's been given, etc. I might just pause there. The only slides I have after that are to do with COVID, and maybe we can just skip through that very quickly. That's fine, Linda, we'll stop there. I think there's lots of questions in the chat and things we need to cover.
Yes, Ram, as you said, there's been quite a few questions and some topics of conversation in the chat. So what I'll do first of all maybe is just start off with a few questions and then maybe invite a couple of people to make some comments as they've made some comments in the chat.
There's a bit of disturbance on your microphone, Linda, but I don't know if you can change that.
Okay, I will maybe try and move around a little bit and see whether it's any better. Better now?
No, carry on. Anyway, it's fine. We'll carry on.
Okay, well, the first question is around cerebral edema and whether there's been an increase in that with the current BSPEG guidelines that we've noticed particularly ourselves.
I think the short answer to that question is that we don't know yet. Remembering that cerebral edema is a very uncommon event. The absolute rate incidence of cerebral edema is about 1% of all DKA patients. Now, we recognize CATS referrals of DKA patients are obviously the sicker end of the spectrum, therefore the risk of cerebral edema is obviously higher. But despite that, the risk of seeing a patient with cerebral edema is very small. So the total numbers of patients that we would need to see some change is going to be in the matter of dozens rather than in single digits. We haven't got to that point yet. There is an active discussion going on at the national pediatric critical care level about starting a prospective audit of DKA management across peds, acute pediatrics and critical care to look at this. But even then, it's going to take several years of data collection to actually figure out whether the rate has gone up or not. But as it stands, I anecdotally don't think that there's been any specific change, but we are very poor anecdotally to notice these things. So I would really recommend some systematic way of collecting the data. I don't know, Linda, if you want to say anything about that.
I pretty much reiterate what you said, that the incidence is, I think, fairly low overall, but it's definitely obviously something that we intend to look out for in all of our referrals, and make sure that if there is any sort of presenting features, anything concerning, that we do, we would treat those with a relatively low threshold. But you're right, the actual data in terms of kind of numbers and evidence behind it is very limited, so that's definitely hopefully something that we'll be able to see in the future years.
Yeah, Usha's put in the chat that BSPED are planning a prospective audit and the tool is being developed. I think we know this. I think Ram Thomas from Sheffield is the pediatric intensivist on the BSPED group and is part of the Pediatric Critical Care Society group that are considering this prospective audit. So yes, I think probably the people are linked up now.
Okay. Then we've got another question. You talked very briefly about the different types of fluids that you can have at your disposal to treat patients with. Seema has asked whether there's any advantage or any particular evidence supporting the use of Hartmann's over any of those other fluids in that context.
So that trial that I very quickly skipped through is a trial of small numbers of patients comparing Hartmann's versus 0.9% saline sodium chloride, and did show some differences in the small randomized trial where they showed that the length of stay in PICU was shorter for Hartmann's patients, and the total amount of fluid replacement over the total period of time that they had the fluid replacement over was smaller for Hartmann's patients. Not 100% clear whether that is, those weren't the primary outcomes. So I would be very careful to interpret them as secondary outcomes, which were not powered to be looked at. And in fact, it was a very small trial. So the short answer is we don't really know, but I can't imagine why Hartmann's is going to be any worse than 0.9% sodium chloride.
Okay, great. And we talked very briefly about cerebral edema and the use of hypertonic saline in the context of that, and how often we do maybe suggest if there's any concerns around the conscious level that treating teams do go ahead and do that. On that, Eddie Chung has asked whether or not the reduced level of consciousness may be related to hyponatremia, how you go ahead and monitor the progress, and also how much and how often do you give hypertonic saline, or how much hypertonic saline can you give?
maybe just tackling the second question, how much and how often can you give hypertonic saline? I think the intent of giving hypertonic saline in this case would be to reduce raised ICP, and the physiological studies suggest that if you give a bolus of 3 mils per kilo of 3% saline, you have a reduction in intracranial pressure, and this is obviously in traumatic brain injury patients, not specifically DKA patients. But you have a peak effect within about an hour, but your effect wears off in about 3 to 4 hours. And that is independent of the rise in sodium. So whether your sodium rises or not, you still get this effect in TBI patients. So I suppose a reasonable extrapolation would be that if you give a dose, it probably works for an hour or so, or within the hour or so, and then maybe a couple of hours to 3 hours later, the effect is waned, whether the sodium rises or not. So that may help us to decide how frequently to give it. So certainly in our practice, if we don't see a response, or if we see a response clinically, but it starts fading, we would give a repeat dose within the sort of first 1 or 2 hours. So it's definitely worth giving repeat doses. And then I suppose the question about treatment of decreased level of consciousness related to hyponatremia and how to monitor the progress. I think this is difficult because there are many confounders here about the decreased level of consciousness. Clearly, cerebral edema being one of the key features. Cerebral edema seems to be a very sort of mysterious kind of syndrome, which is not clearly related to either the level of sodium or the level of acidosis, or anything else. Now, there are only epidemiological and physiological studies that link the cerebral edema to the sodium and the corrected sodium rising, whereas that it isn't that clear what the cause of the cerebral edema is. So the BSPED guidelines are based on the fact that cerebral edema may be related to hypovolemia, and that's why they recommend more fluid. So I suppose the short answer to your question is it's quite complicated to work out whether the decreased conscious level is from the hyponatremia, but we would monitor the decreased conscious level exactly the same way, whatever the etiology might be, which is clearly to do the sort of standard things we do to monitor in terms of impact on airway, impact on airway compromise, impact on hypoventilation, and obviously managing the airway would take precedence over anything else. I don't know if that is the question, specifically the question you were asking.
Okay, and then there are a few comments from Usha in the chat around, I think, the next lot of these DKA guidelines which are going to be published. I think one of the key things is what you talked about, Ram, about identifying the features of shock. So I think that's something that's really important for people to start to look out for the next set of guidelines. I think we should also mention that the final guideline is being updated based on the recent NICE guidelines. I think a bit more information coming from the special interest group. So I think that's obviously going to help inform the next lot of guidelines that will be produced. Okay, I think Arundam had a question, so I'm going to try and see whether I can unmute him. Arundam, do you want to go ahead? You still there, Arundam? Okay, I think Geeta also had a question, so I can try and unmute her. Geeta, hopefully you should be able to unmute yourself and ask a question. unfortunately, for some reason, that's not popping up, allowing you to speak orally, but go ahead and do put your questions into the Zoom or onto Slido. At the moment, it doesn't look as though we've got any more questions or any more comments on Slido or in the Zoom chat. So what I might do then is just wrap things up and allow everybody to go stretch their legs, have a bit of a walk around while we get set up for the next speaker, who's going to be Elise Randall talking about inherited metabolic disease. So if everybody comes back for about 11:10, that would be great. Thank you.
Eddie's just clarified about the question on hyponatremia, any recommended rate of sodium rise. I suppose the simple answer is that if it doesn't exceed the 5 millimoles per liter over 4 to 8 hour tracking window, then that is fine. I think if it's rising much faster, then it indicates a lack of sufficient fluid. So we would obviously liberalize the amount of fluid in that situation. At the moment, the 5 millimole per liter rise over 4 to 8 hours or fall within that time window seems to be less risky in terms of cerebral edema. So that probably is our target, that we should aim for it to be no more than 5 rise or fall within the 4 to 8 hour time window that we are measuring it in.
You want to take 5 minutes to go a bit of a walk around and then come back for 10 past, and we'll have Elise set up ready to go on to her next presentation.